This conference will now be recorded.
Good afternoon, all of you. Hello, good afternoon. Am I audible?
Yes, sir, audible, sir.
Yeah, good afternoon. So we are discussing about antenatal care. Anybody, what is antenatal care?
Care for the woman after conception to the start of the delivery.
Okay, very good. So what were the minimum number of antenatal visits that were suggested?
13, sir.
Hello,
13, sir.
I'm asking
13, sir.
minimum number of antenatal visits. Minimum.
4, sir.
So when? Four antenatal visits were minimum. Okay. So when? What was the time period? At what time they have to visit? Anyone? In my last class, I told this was an important Viva question. ఎప్పుడమ్మా 4 విజిట్స్ అన్నారు మినిమమ్ అది ఆ 4 విజిట్స్ ఎప్పుడు ఓకే వాట్ వాజ్ ద మినిమం కాకుండా నార్మల్ గా యాంటీనేటల్ విజిట్స్ ఎన్ని వాట్ వాజ్ ద నార్మల్ యాంటీనేటల్ విజిట్స్ హలో హలో am I audible?
Yes. Yes, sir.
సో నార్మల్ యాంటీనేటల్ విజిట్స్ ఎన్నమ్మా
4, sir.
దట్ ఈస్ మినిమం నెంబర్ ఆఫ్ యాంటీనేటల్ విజిట్స్ ఐఎమ్ ఆస్కింగ్ నార్మల్ ఒక ప్రెగ్నెంట్ ఉమెన్ యాంటీనేటల్ పీరియడ్ లో ఎన్నిసార్లు హెల్త్ సెంటర్స్ ని విజిట్ చేయాలి
13. Sir, 13.
యా వెరీ గుడ్ ఎప్పుడెప్పుడమ్మా
First 2 trimesters, monthly once, and last trimester lo twice.
అండ్ ఇన్ ద లాస్ట్ మంత్
Twice. Twice, sir.
లాస్ట్ మంత్ వీక్లీ వన్సా లేదంటే ట్వైసా టోటలీ 13 కదా 13 అని
Weekly
చెప్పారు
one. Weekly once.
యా ఓకే సో మినిమం అని ఎందుకు పెట్టారమ్మా వై షుడ్ నార్మల్ విజిట్స్ ఆర్ 13 దెన్ మినిమం విజిట్స్ ఆర్ 14 మినిమం విజిట్స్ ఆర్ 4 మినిమం విజిట్స్ అని ఎందుకు పెట్టారు వై
కొంతమందికి యాక్సెసిబిలిటీ తక్కువగా ఉండొచ్చు.
ఓకే ఎనీ మోర్ ఆన్సర్స్
టీటీ డోసింగ్స్ అవన్నీ అక్కడే హాస్పిటల్స్ లోనే
ఓకే ఎనీ మోర్ ఆన్సర్స్ Okay, let's start our topic for today. Preventive services for mothers, that is antenatal checkup. ఇది లాస్ట్ వీక్ కొంచెం చెప్పామమ్మా, బట్ రివ్యూ లిటిల్ రివ్యూ. సో మనం ఇనిషియల్ గా ఏం చేయాలి? హిస్టరీ టేకింగ్. సో డ్యూరింగ్ ద ఫస్ట్ విజిట్ ఏ డీటెయిల్ హిస్టరీ టేకింగ్ ఆఫ్ ఉమెన్ నీడ్స్ టు బి టేకెన్. సో ఫస్ట్ విజిట్ అప్పటి నుంచి హిస్టరీ టేకింగ్ అనేది ఇంపార్టెంట్. సో woman needs to be taken. It includes confirming the pregnancy and identifying whether there were complications during any previous pregnancy confinement that may have a bearing on present one, and identify any current medical or surgical or obstetric conditions that may complicate the present pregnancy. And record the last date of LMP. Record the date of first day of LMP, that is last menstrual period, and calculate the EDD, that is expected date of delivery, by adding 9 months and 7 days of the first day of last menstrual period. And we have to record symptoms if there are any conditions, complications like fever, persistent vomiting, abnormal vaginal discharge or bleeding, palpitations, easy fatigability, breathlessness at rest or on mild exertion, generalized swelling in the body, severe headache and blurring of vision, burning and passing urine, burning menstruation, decreased or absent fetal movements, and a history of any current systemic illnesses like hypertension, diabetes, heart disease, tuberculosis, renal disease, epilepsy, asthma, jaundice, malaria, RTA, that is a reproductive infection. మా ఇది లాస్ట్ టైం ఆల్రెడీ మీకు చెప్పాను, బట్ అందుకే ఎంత ఫాస్ట్గా చెప్తున్నాను. So STDs like sexually transmitted disease, HIV or AIDS. Record family history of hypertension, diabetes, tuberculosis and thalassemias. Family history of twins or congenital malformations. ఇవన్నీ ఏమన్నా ఉంటే అడగాలమ్మా. History of drug allergies and habit forming drugs. And physical examination is also very important. We have to check for pallor. Pallor indicates
Anemia.
yeah, very good. So presence of pallor indicates anemia. The woman should be examined for pallor at each visit. In every visit, the woman should be examined for pallor. Examine women's conjunctiva, nails, tongue, oral mucus, and palms. Pallor should be correlated with hemoglobin estimation. And pulse. And the normal pulse rate is 60 to 90 beats per minute. If the pulse rate is persistently low or high, with or without other symptoms, the woman needs medical attention. So pulse rate should be monitored at each and every visit. And coming to respiratory rate, and normal respiratory rate is 18 to 20 beats per minute. Okay. And edema is an important sign during pregnancy. Edema, swelling which appears in the evening and disappears in the morning after full night sleep, could be a normal manifestation. So the thing what happens is during pregnancy, edema appears in the evening and disappears in the morning after full night sleep. Any edema of face, hands, abdominal wall and vulva is abnormal. If at all edema occurs on face, hands and abdominal wall and vulva, it is abnormal. It is considered abnormal. And edema can be suspected if a woman complains of abnormal tightening of any rings on her fingers. She must be referred immediately for further investigations. So if at all a woman feels like her ring in her finger is very tight, and during that condition, she must be immediately referred to the nearby health center. Okay. If there is edema in association with high blood pressure, heart diseases, anemia or proteinuria, the woman should be referred to the nearby medical officer. And blood pressure, measuring the woman's blood pressure at every visit is a very important thing, and it is important to rule about hypertensive disorders in pregnancy. And hypertension is diagnosed when 2 consecutive readings taken 4 hours or more apart show systolic blood SBP, that is systolic blood pressure, to be greater than or equal to 140 mmHg, and diastolic blood pressure greater than or equal to 90 mmHg. Okay. And high blood pressure during pregnancy may signify pregnancy-induced hypertension or chronic hypertension. If the woman has high blood pressure, check her urine for presence of albumin. Okay. And the presence of albumin together with high blood pressure is sufficient to categorize her as having preeclampsia. Preeclampsia is nothing but high BP with albumin. And refer her to a nearby medical officer if the diastolic blood pressure of woman is above 110 mmHg, and it is a danger sign that points towards imminent hyperclampsia. And the urine albumin should be estimated at the earliest. And if it is strongly positive, the woman should be referred to FRE, that is first referral unit, immediately. And if woman has high blood pressure but no urine albumin, she should be referred to the medical officer to the neighbor PHC. A woman with pregnancy-induced hypertension, pre-eclampsia or imminent eclampsia requires hospitalization, and she must be under observation. Okay. Weight. A pregnant woman weight should be checked at every visit, and normally a woman weight woman gains 9 to 11 kg during her antenatal period or during her pregnancy. Ideally, after the first trimester, a pregnant woman gains around 2 kg per month. So after first trimester, for every month, woman gains 2 kgs per month. And if the diet is not adequate, that is, a woman is taking very less diet than required, she might gain only 5 to 6 kgs during her pregnancy. And an inadequate dietary intake can be suspected if the woman gains less than 2 kg per month. So if a woman weight gain is less than 2 kg per month, it indicates that she is not taking proper diet, and she needs to be put on a food supplementation. With the help of AWW, that is Anganwadi workers, should be taken in this matter, especially for those categories of women who are underweight. Low weight gain usually leads to IUGR, that is intrauterine growth retardation, and results in birth of baby with low birth weight. Okay. And excessive weight gain, that is more than 3 kg in a month, should raise suspicion of pre-eclampsia or twins, that is multiple pregnancy, or if at all a woman is a diabetic, she may gain more than 3 kgs in a month. And take the woman blood pressure and test her for urine for any proteinuria and sugar. And if the blood pressure is high and the urine is positive for protein or sugar, so we have to refer her to the nearby medical officer immediately. And breast examination, observe the size and shape of nipples for the presence of inversion or flat nipples. And coming to abdominal examination, so we have to examine the abdomen to monitor the progress of pregnancy and fetal growth. And the abdominal examination includes measurement of fundal height. At 12 weeks, uterine fundus just palpable per abdomen, and at 20th week, fundus flat at the lower abdomen of umbilicus, and at the 36th week, fundus felt at the level of GV sternum. And the fetal heart sounds. And the fetal heart sounds can be heard after 6th month. And the rate varies between 120 to 140 for beats per minute. And they are usually best heard in the midline, and their location may change because of the position and lie of the fetus. And fetal movements. Fetal movements be felt by examiner after 18th to 22nd week by gently palpating the abdomen. So fetal movement can be felt by after 18th to 22nd week. Okay. And fetal parts. This can be felt about by 22nd week. After the 28th week, it is possible to distinguish between the head, back, and limbs. Okay. And multiple pregnancy. This may be suspected if the uterus is larger than estimated gestational age, or for palpation of multiple fetal parts. Okay. And fetal line presentation. It is relevant only after 32 weeks of pregnancy. An inspection of abdominal scar or any other relevant abdominal findings. And assessment of gestational age. Measurement of gestational age has changed over the time, and the most accurate golden standard for assessment is routine yearly US ultrasound assessment together with the fetal measurements early in the first trimester. Gestation age assessment based on the date of LMP, that is last menstrual period, was previously the most widespread method used and remains the only available method in many settings. So the gestational age and the ED, expected date of delivery, can be calculated uh, by considering the LMP, that is the date of last menstrual period. It is the gold standard method. And the many countries now use best obstetric estimate by that is by combining the ultrasound and the LMP, that is last menstrual period, as an approach to estimate gestational age. And it can have a large impact on the number of preterm births reported. Okay. Coming to laboratory investigations. So the laboratory investigations includes a subcenter pregnancy detection test. And hemoglobin examination. Hemoglobin examination is very important. So it is in order to rule out anemia. So if at all woman is anemic, she must be supplemented with iron and folic acid tablets. And after supplementing these tablets, the woman should be examined for examined hemoglobin levels at each and every visit. If at all she is anemic, and urine test for pregnancy, presence of albumin and sugar, and a rapid malaria test. So these are the tests commonly done at the sub center. Okay. And PHCs, CHCs, and for you, that is first development. That the test conducted are blood grouping, which includes RH factor, VDRL, HIV testing, rapid malaria test, blood sugar testing, and HBsAg for hepatitis B infection. Okay. So essential components of every antenatal checkups. So the essential components includes taking patient's history, as we discussed earlier. Taking patient history is very important. Conduct a physical examination, measure the weight, blood pressure, and respiratory rate, and check for pallor and edema. So BP measurement, checking BP at every visit, checking weight and respiratory rate, and are very important. We have to check if at all there is a presence of any pallor or not. Pallor checking and edema checking is also important. Pallor indicates that the woman is anemic. If at all the woman is pallor, she should be supplemented with iron and folic acid tablets. So if at all the hemoglobin level is very low, she must be advised for blood transfusion at the earliest, or else the growth may be retarded and may affect the growth of the baby. Okay. Conduct abdominal palpation for fetal growth, fetal lie, and auscultation of fetal heart sounds according to as per the stage of pregnancy. Carry out laboratory infection investigations like HB estimation and urine test for sugar and proteins. Okay. And interventions and counseling. So it includes iron and folic acid supplementation and medications as needed, and immunization against tetanus. So TT immunization is also important, and a group or individual instruction on nutrition, family planning, self-care, delivery and parenthood, and home visiting by a female health worker or trained DAI. So home visiting is very important. So the thing is, most women means some working women, they are not having idea of these antenatal checkups. They fail to come to health centers at the insufficient time. So it is the duty of a female health worker to train them or to educate them regarding the importance of these antenatal checkups. So they have to educate them, and they have to make arrangements for their antenatal checkups. By doing so, by coming for regular antenatal checkups, we may prevent the pregnancy-related complications, and we may control the maternal mortality and as well as infant mortality. Okay. Referral services. If at all there are any referral services, and inform the women about this central government schemes like Jani Suraksha Yojana and other incentives offered by the government. Okay. Anybody, what is RBSK? What is RBSK? అమ్మా మీకు ICDS అంగన్వాడీ సెంటర్కి వెళ్ళినప్పుడు ఒక స్కీమ్ గురించి ఎక్స్ప్లెయిన్ చేశాము. What is PMMVY? What is PMMVY? Pradhan Mantri
Matri Vandana Yojana.
Yeah, very good. It is Pradhan Mantri Matrutva Vandan Yojana. సో మీరు ఏంటంటే ఎగ్జామ్లో ఈ యాంటీనాటల్ చెకప్స్ మీద ఏమైనా క్వశ్చన్స్ వస్తే మీరు ఆ స్కీమ్స్ గురించి రాస్తే ఇట్ విల్ బి అడిషనల్ మార్క్స్ విచింగ్ ఫర్ యూ. టెక్స్ట్ బుక్ లో ఉన్నది ఉన్నట్టే కాకుండా మీరు అంగన్వాడీ హెల్త్ మేము తీసుకునే విజిట్స్ కి చూసి విజిట్స్ లో ఎక్స్ప్లెయిన్ చేసిన స్కీమ్స్ గురించి కూడా రాశారనుకోండి, విల్ బి మోర్ మార్క్స్ విచింగ్. ఓకే. And risk approach, and the central purpose of annual care is to identify high risk cases at the earliest. So by identifying at the earliest, we may prevent the complications from a large group of antenatal mothers and arrange for them skilled care while continuing to provide appropriate care for all mothers. And this case comprises the following: that is elderly preemie. So elderly preemie is nothing but pregnancy at the age of 30 years and above, and short stretched preemie, that is 140 centimeters and below, and malpresentations, which includes breech and transverse lie. So what are the normal presentations? Name some presentations. What is cephalic presentation? What is breech and what is transverse lie? What is cephalic?
It's a normal presentation, sir.
Yeah, then what is about breech?
Head of the baby is towards the sternum, and buttocks will be the presenting part.
Okay, very good, very good. Then what is transverse lie?
Transverse position, horizontally.
Yeah, transverse position. Yeah, very good. So these are all malpresentations. Okay. So malpresentations includes breech and transverse lie, and antepartum hemorrhage, and threatened abortion, preeclampsia and eclampsia, and anemia. So at every visit, women should be examined. Women should be examined if at all there is any pallor or not. So if there is pallor, she should be supplemented immediately with iron and folic acids. So if the HB level of woman is very low, she must be advised for immediate transfusion, and hemoglobin levels should be checked at every visit if the woman is anemic. And twins and hydramnos, and previous stillbirths, IUDs, that is intrauterine death, manual removal of placenta. LLE grand multiparas, prolonged pregnancy, that is 14 days after EDD, expected date of delivery, and if that all there is any history of previous cesarean or instrumental delivery. All these are risk approach. I repeat, a risk approach includes elderly preemie, that is 30 years and above, women aged 30 years and above, and short stretched preemie, that is 140 centimeter and below, and malpresentations, which include breech and transverse lie, antepartum hemorrhage, threatened abortion, pre-eclampsia and eclampsia we are already discussed, anemia, twins, hydramnios, previous stillbirths, IUDs, that is intrauterine deaths, manual removal of placenta, and early grand multiparas, prolonged pregnancy, that is 14 days after the expected date of delivery, and history of previous cesarean or instrumental delivery. All these are risk approach. Okay. And pregnancy associated with general diseases like cardiovascular diseases and renal diseases like CKD, chronic kidney disease and acute renal failure, diabetes, tuberculosis and liver diseases, malaria and convulsions, asthma and HIV, reproductive infection, and STDs, that is sexually transmitted diseases, and treatment for infertility, 3 or more spontaneous consecutive abortions. All these are risk factors. And home visits. So home visiting is the backbone of all MCH services. Okay. Even if the expectant mother is attending the antenatal clinic regularly, it is suggested that she must be paid at least one home visit by the health worker, female or public health nurse. So even the mother is attending the ANCK antenatal clinic regularly, and it is suggested that she must be paid at least one home visit by health worker or public health nurse. More visits are required if the delivery is planned at home. So the purpose of more visits is for the successful delivery, delivery of baby if the delivery is planned at home. So If at all there is planned at home, more visits are required. Okay. And prenatal advice. A major component of antenatal care is prenatal advice. And the mother is more receptive to advice concerning herself and her baby at this time than all other times. So, and the talking point should cover not only the specific problems of pregnancy and childbirth, but overflow into family and child health care. So, prenatal advice is very important. Okay. Diet. So a pregnancy in total duration consumes about 60,000 kilocalories over and above the normal metabolic requirements. And the lactation demands about 550 kilocalorie a day. Further, survival is correlated with birth weight, and birth weight is correlated to weight gain of mother during pregnancy. I repeat, lactation demands about 550 kilocalories per day, and child survival is correlated with birth weight, and birth weight is correlated to weight gain of mother during pregnancy. And then on average a normal healthy woman gains about 9 to 11 kg of weight during pregnancy. It is important for your question. A healthy woman gains about 9 to 11 kg of weight during her pregnancy. So several studies have indicated that weight gain of poor Indian women averaged 6.5 kg during pregnancy. So women who are not taking adequate diet gain this 9 to 11 kg, and their weight gain is around 6 to 5 kg during pregnancy. If maternal stores of iron are poor, and if enough iron is not available to the mother during pregnancy, it is possible that fetus may lay down in insufficient iron stores. So at every visit, woman should be advised to take iron and folic acid tablets. So if at all woman is not taking that iron and folic acid tablets, it may leads to low HB levels and insufficient iron stores in the of the fetus. And a balanced and adequate diet is therefore of utmost importance during pregnancy and lactation to meet the increased needs of mother and to prevent nutritional stress. Okay, and the balanced and adequate diet is very important to prevent nutritional stress. And coming to personal hygiene, it is of equal importance regarding personal cleanliness. It includes personal cleanliness. The need to bath every day and to wear clean clothes should be explained, and the hair should also be kept clean and tidy. And rest and sleep. 8 hours sleep should be mandatory, and it is very important. And at least 2 hours rest after midday meal should be advised. So, on an average, 8 hours sleep must be very, very important. And post lunch, 2 hours rest is advised. Both constipation should be avoided by regular intake of green leafy vegetables, fruits, and extra fluids. Purgatives like castor oil should be avoided to relieve constipation. And the woman is advised to take more fiber diet. More fiber diet may prevent the constipation and exercise. A light household work is advised, but manual physical labor during late pregnancy may adversely affect the fetus. So, light household work and light exercises are advised during pregnancy. Okay. Smoking should be cut down during pregnancy. So, aspirant mothers who smoke heavily produce babies much smaller than average. It is because nicotine has vasoconstrictor influence in the uterus and induces a degree of placental insufficiency. So, smoking may produce very small babies. Okay, or smoking may result in growth retardation of the baby. And the adverse effects of smoking range from low birth weight to increased risk of perinatal death of the infant. Okay, so smoking should be discouraged during pregnancy. And alcohol. Evidence is mounting that alcohol can cause a range of fertility problems in women. Moderate to heavy drinkers who became pregnant have greater risk of pregnancy loss. And if they do not abort, their children may have various physical and mental problems. So what happens is moderate to heavy drinkers have the problem of pregnancy loss. Pregnancy loss is there, and if they do not abort, the child born to these heavy drinkers may develop various physical and mental health problems. So drinking should be very dangerous and it should be avoided during pregnancy. And heavy drinking has been associated with fetal syndrome, and it includes intrauterine growth retardation and developmental delay. So it may lead to heavy drinking may lead to intrauterine growth retardation and developmental delay. And dental caring. Advice should also be given about oral hygiene, and quality should be restricted during the last trimesters. Okay. Drugs. The use of drugs that are not absolutely essential should be discouraged. So, now the essential drugs should be encouraged, and those are not required should be discouraged during pregnancy. Certain drugs taken by the mother during pregnancy may affect the fetus adversely and cause fetal malformations. So drugs may have some effect on fetal development also. So certain drugs which are not essential, if at all that drugs are taken by the mother, it may have the impact on the developing fetus and may result in growth retardation, okay, and fetal malpresentation, malformations also. And the classical examples are like includes the thalidomide and hypnotic drug, which cause a deformed hands and feet of babies born, and the drug proved most serious when taken between 4 to 8 weeks of pregnancy. Radiation. Exposure to radiation is a positive danger to developing fetus. The most common source of radiation is abdominal X-ray during pregnancy. And case cohort studies have shown that mortality rates from leukemia and other neoplasms were significantly greater among children exposed to intrauterine X-ray. So there may be high chance of leukemia and other neoplasms to the children of mother who are exposed to intrauterine X-ray. Okay, and this is addition to congenital malformations such as microcephaly. What is microcephaly? Okay, microcephaly is nothing but the head of the children is the size of the head is very small. Okay, this mainly because of poor development of brain. Okay, so these are all the results of radiation. Rest of the topic we will discuss in our next class. Okay, roll number 1. One absent. Two absent. Two. 3.
3 present, sir.
4.
4 present, sir.
5. 5 absent. 6.
6 present, sir.
7.
6 present, sir.
7 present,
7.
sir. 7
8.
present, sir.
8 present, sir.
9.
8 present, sir.
9.
present, sir. 9 present, sir.
10.
10 present, sir.
11. 11 absent. 12.
12 present, sir.
Okay, 13.
13 present, sir.
14. 14 absent. 15.
15 present, sir.
16.
16 present, sir.
17.
17 present, sir.
18.
18 present, sir.
19.
19 present, sir.
20. 20 absent. 21.
21 present, sir.
22.
22 present, sir.
23.
3 present, sir. 20 present, sir.
24.
24 present, sir.
25.
25 present, sir. 25 present, sir.
26.
26 present, sir.
27.
present, sir. 27 present, sir.
28.
28 present, sir.
29. 29 absent. 30,
30 present, sir.
31, 31 absent, 32,
32 present, sir.
33,
33 present, sir.
34,
34 present, sir.
35, 35 absent, 36,
36 present, sir.
27,
Yes, sir. 37 present, sir.
38, okay,
38 present,
38,
sir. 38 present, sir.
39,
39 present, sir.
40,
40 present, sir.
41,
41 present, sir.
42,
42 present, sir.
43, 43, 44,
44 present, sir. 44 present, sir.
45, okay, 45, 45 absent, 46,
46 present, sir.
47,
47 present, sir.
48,
48 present, sir.
49,
Present, sir. 49 present, sir.
okay, 50,
50 present, sir.
50 absent, okay, 51,
50 present, sir.
okay, 50, okay, 51, 51 absent,
51 present, sir.
52,
52 present, sir. 52 present, sir.
53,
53 present, sir.
54,
54 present, sir.
55, 55 absent, 56,
56 present, sir.
57,
57 present, sir.
58,
58 present, sir.
59,
59 present, sir.
60,
60 present, sir.
61, 61 absent, 62,
62 present, sir.
63, 63 absent, 64,
64 present, sir.
65,
65 present, sir.
66,
66 present, sir.
67,
67 present, sir.
68, 68 absent, 69,
69 present, sir.
70, 70 absent, 71,
71 present, sir.
72, 72 absent, 73,
73 present, sir.
74,
74 present, sir.
75,
75 present, sir.
76,
76 present, sir.
77,
76 present.
okay, 77, 77 absent, 78,
78 present, sir.
79,
79 present, sir.
80, 80 absent, 81, 81 absent, 82,
82 present, sir.
83, 83 absent. 84. 84 absent. 85.
85 present, sir.
86. 86. 86 absent. 87. 87 absent. 88. 88 absent. 89.
89 present, sir.
89.
89 present, sir.
90. 90 absent. 91. 92.
92 present, sir.
93.
93 present, sir.
94.
94 present, sir.
95.
95 present, sir.
96.
96 present, sir.
97. 97 absent. 98.
98 present, sir.
99.
99 present, sir.
100.
100 present, sir.
101.
101 present, sir.
102.
102 present, sir.
103. 103 absent. 104. 104 absent. 105.
105 present,
104
sir.
present, sir. Sir, 104
106.
present. Sir, 104 present,
106.
sir.
106 absent. 107.
107 present, sir.
Sir, 106
108.
present, sir.
Okay, 104. 108. 107. 107.
107 present, sir.
108.
108 present, sir.
109.
109 present, sir.
110.
110 present, sir.
111.
111 present, sir.
112. 112 absent. 113. 113. 113.
120 present, sir.
114.
120 present, sir.
114 present, sir. 114
115.
present, sir.
115.
Sixteen present.
115 present, sir.
116.
ఏం తేడా ఉందట నువ్వెవరంటూ అడిగితే నన్నెవరైనా ఇల్లాగే కడదాకా ఓ ప్రశ్ని
120 present, sir.
119 present, sir.
117 present, sir.
120 present, sir.
121.
121 present, sir. 121 present, sir.
122 present, sir.
123.
122 present, sir.
123. 123.
124 present, sir. 124 present.
123.
124 present, sir.
125.
125 present, sir. 125 present,
126.
sir.
127.
127 present, sir.
128.
present, sir.
126 absent. 126. 126. 127.
127 present, sir. 127 present, sir.
Okay, 128. 128. 128 absent. 129.
129 present, sir.
130.
130 present, sir.
Sir, 55 present,
131.
sir.
131 present, sir.
132.
132 present, sir.
133.
133 present, sir.
134.
Present, sir.
135. 135 absent. 136. 136 absent. 137. 137. 137 absent. 138.
138 present, sir.
139. 139 absent.
Sir, 55 present, sir.
139 absent. 140. 140. 140 absent. 141.
141 present, sir.
142. 142 absent. 143.
143 present, sir.
144.
144 present, sir.
145.
145 present, sir.
146. 146 absent. 147.
147 present, sir.
148.
present, sir.
149.
149 present, sir.
150. 150 absent. 151.
151 present, sir.
152. 152 absent. 153.
Sir, please, sir. 150 present, sir.
153. 153 absent. 154. 154 absent. Okay, thank you.
Thank you, sir.